Eyelid and lacrimal drainage system neoplasms. Classification: benign tumors of the epidermis, premalignant and malignant epithelial tumors, glandular and adnexal tumors of eyelids, melanocytic tumors of eyelids, neurogenic tumors of eyelids, vascular tumors, lymphoid tumors, xanthomatous tumors, metastatic tumors of eyelids, and tumors of lacrimal drainage system. Now we'll talk about some terminology. Hyperkeratosis is increased production of surface keratin, whereas parakeratosis is the presence of nuclei in keratin. Acanthosis is increased thickness of the prickle cell layer. Pseudoepitheliomatous hyperplasia is downward proliferation of acanthotic cells. It is reactive change over areas of inflammation or neoplasia. Dysplasia. Dysplasia is non-neoplastic cellular proliferation. Atypical cells are present in the epithelium. There is loss of polarity, loss of uniformity and architectural orientation of normal cells. Pleomorphism is variation in size and shape. Anaplasia. Anaplasia is the lack of structural and functional differentiation of cells, which means malignancy. There is loss of polarity, severe pleomorphism, and marked hyperchromatism. Nuclear to cytoplasmic ratio is 1:1, in contrast to the normal ratio, which is 1:4 or 1:6. The nuclei show variability in size and shape, coarse clumped chromatin, and large nucleoli. Mitosis is frequent and atypical, and there are giant cells. Carcinoma in situ is anaplasia with intact basement membrane, whereas invasive carcinoma is anaplasia with breached basement membrane. Basics for histopathological evaluation. Basal cells are blue, squamous cells are pink, benign lesions are above the plane of epidermis, and malignant lesions are below the plane of epidermis. Basics for histopathological evaluation: seborrheic keratosis, benign papilloma or acanthosis, basal cell carcinoma, squamous cell carcinoma. Benign tumors of epidermis. Squamous cell papilloma. This is a growth pattern characterized by upward proliferation of epithelium. It is elevated, well-defined tumor with a rough surface that could be sessile or pedunculated. Microscopically, there is a vascularized connective tissue core with hyperkeratosis, parakeratosis, and acanthosis. Keratoacanthoma. Keratoacanthoma is a benign self-limiting condition of upper portion of hyperplastic hair follicle and associated sebaceous glands. It is considered as a benign variant of pseudoepitheliomatous hyperplasia. It is regarded as a variant of low-grade squamous cell carcinoma. Clinically, it is as basal cell carcinoma, whereas the pathology is as squamous cell carcinoma. Keratoacanthoma has a sudden onset and is a rapidly enlarging hyperkeratotic lesion within 6 to 8 weeks. It appears as dome-shaped nodule with central keratin-filled crater and elevated rolled margins. It undergoes gradual involution over 3 to 6 months. Microscopically, there is a central keratin plug. There are acanthotic, hyperkeratotic, and dyskeratotic epithelial cells. No dysplasia is present, and inflammatory cells are common. Seborrheic keratosis. Seborrheic keratosis is a benign papillomatous proliferation of basal cells affecting the elderly. It appears as an elevated brown-gray lesion with greasy keratin crust. It is well demarcated, brownish, lobulated, with a rough surface. Microscopically, there are hyperkeratotic basal epithelial cells, outer acanthosis, typical keratin cysts within basaloid proliferation, horn pseudocysts, and there is no dermal invasion. Inverted follicular keratosis is an irritated seborrheic keratosis. Microscopically, it is a papilloma with pseudoepitheliomatous hyperplasia and keratotic invagination. Inverted follicular keratosis is an irritated seborrheic keratosis. Microscopically, it is a papilloma with pseudoepitheliomatous hyperplasia and keratotic invagination. Other types include hyperkeratotic, clonal, irritated, inverted follicular keratosis. Premalignant surface epithelial tumors. Actinic keratosis. Round scaly keratotic lesions of exposed skin. It affects older, fair-skinned males due to chronic sunlight exposure. It appears as multiple slightly elevated erythematous lesion with cutaneous horns. Microscopically, there is elastotic degeneration in the dermis with hyperkeratosis, elongated reed pegs, acanthosis, and dysplasia. Actinic keratosis may undergo spontaneous regression, 25% over 12 months follow-up, or undergo malignant transformation into squamous cell carcinoma. The incidence is 0.25% per year. Radiation dermatitis. Early changes occur within 2 to 4 weeks and include erythema in response to 6 gray of radiation, desquamation in response to 50 to 60 gray of radiation. Hair loss is permanent at 30 gray of radiation per 3 weeks. Intermediate changes, fibrosis leading to entropion or ectropion. Late changes within 1 to 2 years, thinning of skin, pigmentation, and telangiectasia, also necrosis. Xeroderma pigmentosa. It is an autosomal recessive, ultraviolet B-induced damage to DNA with inability to repair. There is focal hyperpigmentation, atrophy, and telangiectasia in exposed skin. Xeroderma pigmentosa predisposes to squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. Malignant surface epithelial tumors. Basal cell carcinoma. It is an epithelial proliferation arising from basal layer of epidermis, primary epithelial germ cells, pluripotential embryonal cells in the deepest layer of epidermis. Basal cell carcinoma represents more than 90% of eyelid malignancy. It is related to sun exposure in fair complexion skin, middle age or elderly. Distribution: lower eyelid 55%, medial canthus 30%, upper eyelid 10%, and lateral canthus 5%. Basal cell carcinoma is a locally invasive tumor that does not metastasize. Types of basal cell carcinoma. Nodular or nodulo-ulcerative type. It appears as well-defined, elevated, firm erythematous nodule with central crater or ulcer. The tumor is locally invasive. It induces madarosis and may be pigmented, resembling. Microscopically, there are nests of deeply basophilic cells with lobules of closely packed nuclei with peripheral palisading and connective tissue septa in between. The morphiform or sclerosing type. It appears as firm, slightly elevated lesion with poorly defined border. The tumor is locally invasive and may lack ulceration. Morphiform or sclerosing type of basal cell carcinoma also induces madarosis. Microscopically, there are tumor cell cords with poorly defined margins. Invasion into dermis occurs and extensive fibrosis is present. Another type of basal cell carcinoma is the orbit eroding type. The tumor totally erodes the eyelids, eye globe, orbital soft tissue, and orbital bone, leaving a large defect. Nevoid basal cell carcinoma syndrome or Gorlin-Gold syndrome. This is an uncommon autosomal dominant multisystem disorder occurring in 0.7% of basal cell carcinoma as multiple nevoid basal cell carcinoma early in life. There are autogenic keratocysts, bifid ribs, plantar and palmar pits. Squamous cell carcinoma. This is an epithelial proliferation arising from squamous layer of epidermis, primary epithelial germ cells, pluripotential embryonal cells in the deepest layer of epidermis. Squamous cell carcinoma represents less than 5% of malignant eyelid tumor. Predisposing factors include actinic keratosis and xeroderma pigmentosa. Squamous cell carcinoma appears as a raised keratinized mass. The ulcer has everted and hard edge, indurated base more than basal cell carcinoma, and nodular and infected surface. Microscopically, we can find invasive squamous cells, pleomorphism, that is variability in size and shape of cells, pink eosinophilic scanty cytoplasm with hyperchromatic nuclei, dyskeratosis and mitosis, intraepidermal keratin pearls, cellular atypia, multinucleated cells, and the stroma is scanty with eosinophilic cytoplasm. Squamous cell carcinoma may spread locally and thus destroying the face to the regional lymph nodes, 15% of tumors more than 6 mm thick, but the systemic metastasis is rare. Glandular and adnexal tumors. Sebaceous gland carcinoma. This is a highly malignant neoplasm arising from meibomian glands, Zeiss glands, carancular and eyebrow sebaceous glands. It constitutes 5% of malignant eyelid tumors, and thus more common than squamous cell carcinoma. The tumor is multicentric, affecting upper eyelids more than the lower eyelids. The palpebral conjunctiva and cornea may be involved through pagetoid spread. Sebaceous gland carcinoma is more common in females. Sebaceous gland carcinoma appears as a solitary yellow, non-ulcerating nodule. There is madarosis with destruction of meibomian gland orifices. In the diffuse form, there is pagetoid growth pattern mimicking unilateral chronic blepharoconjunctivitis. This gland involvement appears as yellow nodule at the eyelid margin. Microscopically, there are lobules and sheets of malignant basophilic cells. The tumor is anaplastic with epidermal invasion and inflammatory cells. There are intralesional lipids, as demonstrated by lipid red oil O stain. Microscopically, there are lobules and sheets of malignant basophilic cells. The tumor is anaplastic with epidermal invasion and inflammatory cells. There are intralesional lipids, as demonstrated by lipid red oil O stain. In sebaceous gland carcinoma, orbital invasion occurs in 17% of cases, lymph node involvement in 28% of cases. The mortality rate is 14 to 40%, and the earlier the detection, the better the prognosis. Muir-Torre syndrome. This is a hereditary autosomal dominant syndrome with sebaceous gland tumors, hyperplasia, adenoma, and carcinoma. Also keratoacanthomas and internal malignancy, like that of colon, cancer, or stomach, and so on. Eccrine sweat gland tumors, syringoma, syringocystadenomas, eccrine acrospiroma, carcinoma, eccrine or apocrine. Nodular hydradenomas. Origin, eccrine glands. Etiology, affects adults mainly in the face and upper trunk. Single nodule, less than 1 cm in diameter. Pathology, solitary solid or cystic dermal nodule with stretched reddish-blue overlying skin. Microscopic picture. Lobulated masses of epithelial cells within the dermis. Branching tubular lumina lined with a single layer of cuboidal or columnar cells are found within the lobules of epithelium. Cystic spaces containing faint eosinophilic material. The solid part of the tumor shows 2 cell types: small dark cells with dark nuclei and scanty eosinophilic cytoplasm, and cells with clear cytoplasm, accumulation of glycogen. Papillary syringadenoma, syringcystadenoma papilliferum. Origin, adenoma of apocrine sweat structures that differentiate towards apocrine ducts. It is a solitary lesion. Sites, 75% in the scalp on top of a pre-existing nevus sebaceous, 25% de novo. Papillary syringadenoma, syringcystadenoma papilliferum. Pathology, smooth plaque in the scalp, becomes raised, nodular, and verrucous. Microscopic picture, cystic spaces invaginating the dermis. Lining consists of a double-layer epithelium formed of luminal highly columnar cells and outer myoepithelial cells. Heavy plasma cell inflammatory infiltrate. Apocrine cystadenoma. Origin, glands of Moll, the secretory rather than the ductal portion. Pathology, multiple cystic lesions limited to eyelid margin, may be pigmented. Microscopic picture, double-layered cuboidal cellular lining which focally becomes more plump and occasionally thrown into papillary folds. Apical apocrine epithelium with decapitation secretion. Basal myoepithelial cells. Oncocytoma. Origin, apocrine glands of the caruncle, lacrimal gland, lacrimal sacs,
and rarely on the eyelids. It represents 3 to 8% of biopsied caruncular masses. It usually affects elderly females. Pathology: small 2 to 5 millimeters, slowly growing solid or cystic red stem mass. Microscopic picture: uniform oval cells with abundant eosinophilic cytoplasm. Small round nuclei with a single nucleolus. Occasional goblet cells are scattered within the epithelial lining of the cystic tumor. Tumor contains cystic and papillary components. Electron microscopy: malformed mitochondria in tumor cells.
Hair follicle tumors. Trichoepithelioma or Brooks tumor, that is an autosomal dominant disorder. Trichofolliculoma and trichilemmoma, that originates from the outer hair sheath, trichilemma. There are glycogen-rich cells with lobular acanthosis. The palisade pattern is seen at the boundary of tumor lobules.
Trichoepithelioma, Brooks tumor. Origin: hair germ cells. Inheritance: autosomal dominant pattern in multiple tumors, Brooks tumor. Develop in adolescence and increase in size and number with age. Pathology: multiple nodular tumors involving face and eyelids. Microscopic picture: multiple horny cysts with fully keratinized center surrounded by islands of proliferating basaloid cells. Cellular stroma is well demarcated from the surrounding dermis. Trichofolliculoma. Origin: represents the most differentiated pilar tumor presenting as a hamartoma. Gross picture: slightly elevated umbilicated nodule showing small white hairs in the central pore. Microscopic picture: central dilated hair follicle filled with keratin surrounded by branching immature hair follicles. There is epithelial dysplasia, partial thickness replacement by atypical cells. Disordered keratocytes proliferation. Parakeratosis with focal loss of granular cell layer and dyskeratosis. Irregular buds of atypical keratocytes extending into the papillary dermis. Underlying dermis shows elastotic degeneration. Squamous cell carcinoma, 0.25% to 3% per year.
Pilomatrixoma or calcifying epithelioma of Malherbe. This is a benign tumor originating from the matrix of the hair root. It is common in children and is located at the head and neck region, eyelid and eyebrow region, where intermediate hair density is high. Microscopically, there are areas of calcification with shadow cells and dark basophilic cells. Chronic granulomatous reaction takes place with calcification and ossification. Melanocytic tumors of the eyelids. Nevus. It is a benign tumor arising from nevus cells, epidermal and dermal melanocytes. It is flat, elevated, sessile or pedunculated papillomatous lesion at the eyelid margin that could be pigmented or non-pigmented. The cilia are intact and there may be kissing nevus. Types of nevi: junctional, compound, and intradermal. Junctional nevi. There are nests of nevus cells at epidermal-dermal junction, and they have malignant potential. Compound nevi. There are nevoid nests at the junction and in the dermis. The junctional component gives malignant potential. Intradermal nevi. This is the commonest variety, and there are nevoid nests that are separated from epidermis by collagen, Grenz zone, and may infiltrate orbicularis muscle. Intradermal nevi is a benign lesion. Microscopically, there is typical nesting of mildly atypical melanocytes. The junctional type shows malignant potential, whereas the compound type is less malignant and the intradermal nevus shows no malignant potential. Oculodermal melanocytosis or nevus of Ota. This is a benign pigmented lesion arising from dermal melanocytes. There is congenital periocular flat cutaneous pigmentation and associated epibulbar and uveal pigmentation. 0.4% of patients with oculodermal melanocytosis develop uveal melanoma. They show slightly more risk of brain and orbital melanoma, whereas eyelid and conjunctival melanoma are extremely rare. Microscopically, there are scattered dendritic dermal melanocytes with focal proliferation of subepithelial melanocytes. This is similar to diffuse congenital blue nevus. Lentigo maligna or Hutchinson melanotic freckle. This is common in face due to sun exposure, but rare in eyelids. It is a premalignant lesion leading to formation of lentigo maligna melanoma. It may present as an eyelid nodule with variable pigmentation or as a progressive growth, vertical, nodular. It may send nodal or systemic metastasis in 35 to 75%. Lentigo maligna melanoma. It constitutes 90% of head and neck melanoma. It is predisposed to by lentigo maligna. The radial growth phase, intraepidermal spread, is followed by a vertical growth phase, intradermal spread. Lentigo maligna melanoma appears as a nodule or plaque with variable pigmentation and has a surround component due to intradermal spread. The eyelid and conjunctiva are involved by extension of tumor cells from malar region. Microscopically, there are fascicles of spindle-shaped cells involving dermis. There is cellular heterogeneity, loss of polarity, and mitotic figures. Lentigo maligna melanoma metastasize in 10% of cases, and the 5-year survival rate is 90%. Nodular malignant melanoma. It constitutes 10% of cutaneous melanoma, and the affected age is 40 to 50 years. It appears as a palpable nodule with rapid growth, only a vertical growth phase, and no surround component. There is early dermal involvement. Nodular malignant melanoma has the worst prognosis, with the 5-year survival rate 44%. Superficial spreading melanoma. It affects younger patients in the non-exposed skin areas, upper back and legs. It appears as a spreading, faintly palpable macule with irregular outlines, and there is variable pigmentation. Superficial spreading melanoma. It affects younger patients in the non-exposed skin areas, upper back and legs. It appears as a spreading, faintly palpable macule with irregular outlines, and there is variable pigmentation. Microscopically, there are small clusters of homogeneous pagetoid nests in all levels of epidermis, prolonged intraepidermal growth phase, invasive phase marked by papules and nodules, white areas of spontaneous regression. The 5-year survival rate of superficial spreading melanoma is 69%. Cutaneous melanoma. It originates from dermal melanocytes. 20% of nodular melanoma and 50% of superficial spreading melanomas arise from nevi. Malignant transformation of cutaneous melanoma is evidenced by change in color, red, white, and blue, sudden darkening, change in size, crusting, bleeding, ulceration, softening or friability, pain, itching, or tenderness, change in shape, rapid elevation of a flat lesion, change in surrounding skin, redness, swelling, satellites, and invasion of surrounding structures. Other factors associated with poor prognosis of cutaneous melanoma: male sex, lymph nodes involvement, mitotic index, absence of lymphocytic infiltrate at the base of the lesion, amelanotic lesions. Levels of cutaneous melanoma. Level 1. The epidermis only is involved while the basement membrane is intact. The 5-year survival rate is 100% in lentigo maligna melanoma. Level 2. There is early invasion of papillary dermis, and the 5-year survival rate is 100% in lentigo maligna melanoma. Level 3. The tumor fills entire papillary dermis, and the 5-year survival rate is 80% in superficial spreading melanoma. Level 4. Reaches reticular dermis, and the 5-year survival rate is 65% in nodular melanoma. Level 5. Invades subcutaneous tissue with a 5-year survival rate of 15% in nodular melanoma. Prognosis of cutaneous melanoma. Involvement of eyelid margin and conjunctiva carries a worse prognosis. The mortality is associated with aggressive tumor, deep invasion, and metastasis. Prognostic factors of cutaneous melanoma. Clark classification. Tumor thickness. If represents less than 0.76 millimeters, there is 100% 5-year survival rate. But if represents more than 1.5 millimeter, the 5-year survival rate is less than 50%. Histopathologic type. Lentigo maligna melanoma carries the best prognosis. Superficial spreading melanoma, intermediate prognosis, while nodular melanoma carries the worst prognosis. Neurogenic tumors of the eyelids. Neurofibroma. Plexiform neurofibroma is part of NF1, which is an autosomal dominant disorder, and the affected chromosome is chromosome 17. Mutation of NF1 gene encoding for neurofibromine protein. It appears as a solitary eyelid nodule, which is rare, no NF, or diffuse plexiform variant found in NF1 and more common. Microscopically, there is proliferation of axons, Schwann cells, and fibroblasts, and there is mucinous degeneration.
Microscopic picture. Proliferation of axons, Schwann cells, and fibroblasts, with mucinous degeneration.
Neurolymphoma or schwannoma. This is a benign tumor of Schwann cell origin. No associated NF. It appears as solitary subcutaneous eyelid nodule, chalazion, and Schwann cell proliferation, Antony A and B. Merkel cell tumor. This is a malignant tumor originating from Merkel cells, the mechanoreceptors for touch, neural crest origin. It affects the elderly and presents as red-blue sausage mass in upper eyelid more than lower eyelid. There are large basophilic cells resembling sebaceous gland carcinoma. Metastasis and death occurs in 25%. Lymphoid tumors of the eyelids. B-cell lymphoma manifests as a firm subcutaneous mass, while T-cell lymphoma presents as mycosis fungoides, more superficial. It is associated with systemic lymphoma and has variable behavior, benign to malignant. Xanthomatous tumors of eyelids, xanthelasma. Yellowish deposits in medial canthal region of upper and lower eyelids. It presents as bilateral placoid yellow elevated lesions. It may be isolated or part of systemic xanthomatosis. It is associated with familial hyperlipidemia and Erdheim-Chester disease. Microscopically, there are lipid-laden perivascular macrophages in the superficial dermis. Fibrous xanthoma, as xanthelasma. Predominant fibrous tissue, histiocyte foam cells. Inflammation is common, and there is rare malignant potential. Histiocytosis X. Letter SEW. Hand-Schuller-Christen, eosinophilic granuloma with rare lid involvement. Juvenile xanthogranuloma. It affects infants and young children and presents as smooth, round, and orange lesions that undergo spontaneous resolution. Microscopically, there are lipid-filled histiocytes in the dermis and Tootun giant cells. Metastatic tumors to the eyelids. Origin: breast, lungs, kidney, melanomas, etc. Eyelid metastasis may represent first sign of systemic malignancy. It presents as rapidly growing eyelid nodule, pseudochalazion, variable pathological findings depending on primary lesion. Poorly differentiated lesion does not indicate primary site. Lacrimal drainage system tumors. Primary lacrimal sac tumors are uncommon. Secondary tumors originate from eyelids and conjunctiva. Squamous papilloma transforms into squamous cell carcinoma. It presents as a firm mass at the medial canthus. Epiphora is present, and lacrimal drainage system tumors are to be differentiated from chronic dacrocystitis. Pathology. Firm mass at medial canthus. Epiphora. Squamous papilloma. Squamous cell carcinoma. Differential diagnosis: chronic dacrocystitis.